Hello, my name is Dr. Banik, and I am Associate Professor of Ophthalmology at the Mount Sinai School of Medicine and Assistant Director of the Neuro-Ophthalmology Service at New York Eye and Ear Infirmary of Mount Sinai. Today, I will be presenting a talk on traumatic optic neuropathy. I have no commercial interest to disclose regarding the content of this talk. After completing this activity, the learner should have improved his or her ability to 1. List the mechanisms of injury in traumatic optic neuropathy. 2. Utilize evidence-based medicine in the management of traumatic optic neuropathy. I would like to begin with a case presentation. This is a 53-year-old male involved in a motor vehicle accident who suffered trauma to the right side of his face. He initially complained of decreased vision in the right eye. On external examination, the patient had evidence of significant periorbital edema around the right eye. He also had a deep laceration over the right brow. His visual acuity was 2200 in the right eye and 20/20 in the left eye. His pupillary exam showed a right relative afferent pupillary defect. His intraocular pressures were 56 millimeters of mercury in the right eye and 14 millimeters of mercury in the left eye. Initially, a CAT scan of the orbits was performed, which revealed no orbital wall or optic canal fracture. In addition, the right orbit appeared to be normal with no retroorbital hemorrhage or sheath hematoma. The optic nerve appeared normal as well. Given the normal CT findings, initially it was unclear as to the etiology of the patient's visual loss. Nevertheless, because of the markedly elevated intraocular pressure, a lateral canthotomy was performed urgently. After the procedure, the intraocular pressure came down to 32 millimeters of mercury in the right eye. However, the patient still had a pronounced relative afferent pupillary defect in the right eye with no improvement in his visual acuity. Subsequently, the diagnosis of traumatic optic neuropathy was made. The options for management of traumatic optic neuropathy may include high-dose intravenous corticosteroids, megadose intravenous corticosteroids, surgical decompression of the optic canal, or observation only. Prior to making any recommendations for this patient, one must first understand the pathophysiology of traumatic optic neuropathy, as well as review the evidence base for its management. Vision loss caused by trauma to the optic nerve is considered traumatic optic neuropathy. This condition is usually seen with high momentum deceleration injuries or frontal or mid-phase trauma. It is estimated to be present in 2 to 5% of cases of craniofacial trauma. Males are more affected than females. Regarding the etiology of traumatic optic neuropathy, the majority of cases result from motor vehicle or bicycle accidents, followed by falls and assaults. Penetrating orbital trauma may also cause traumatic optic neuropathy, whether it be a stab wound, a pellet or gunshot wound, or other type of foreign body. Finally, recreational sports such as paintball or bungee cord injury may result in traumatic optic neuropathy. There are two mechanisms of injury in traumatic optic neuropathy, direct and indirect. Each of these two categories can then be subdivided into anterior and posterior locations. Regarding direct injury in traumatic optic neuropathy, there is anatomic disruption of the optic nerve fibers. Most commonly, this occurs with penetrating orbital trauma. Also, should there be an optic canal fracture, bony fragments may be seen within the optic canal impinging on the optic nerve. Here, in this CAT scan bone window image, we can see on the left that there is a metallic foreign body directly impinging on the optic nerve. Another mechanism of direct injury in traumatic optic neuropathy is an optic nerve sheath hematoma. Here is another example of direct optic nerve injury caused by penetrating trauma with a sharp object. On this CAT scan bone window view, there is a pencil visible just lateral to the optic nerve with its tip impinging near the orbital apex. Here is another example of penetrating orbital trauma in which we have a long, sharp object penetrating the orbit medially, directly through the optic canal into the cranial cavity. Here are examples of direct traumatic optic neuropathy associated with fracture of the optic canal with bony fragments impinging on the optic nerve. In this axial view, we can see that there is disruption of the canal, also visible on the coronal and sagittal views as well. As mentioned earlier, another mechanism of direct traumatic optic neuropathy would be an intrasheath hematoma. This is a histopathologic view of an optic nerve in cross-section in which there is blood visible within the dural sheath circumferentially surrounding the optic nerve. The next category of injury is indirect traumatic optic neuropathy. This usually results from transmission of forces from blunt head or orbital trauma. Indirect traumatic optic neuropathy can result in anterior trauma, in which case the optic nerve is damaged intraocularly. In this fundus photograph, we see an example of optic nerve avulsion, in which the nerve is disinserted from the scleral canal. There is peripapillary hemorrhage with a recessed optic nerve. Here is another example of anterior indirect traumatic optic neuropathy with optic nerve avulsion. Again, there is 360° of peripapillary hemorrhage extending into the vitreous cavity. The optic nerve is not visible within the confines of the scleral canal. One should be suspicious of optic nerve avulsion when there is peripapillary hemorrhage and the scleral canal is obscured by blood. In all cases of optic nerve avulsion, vision is severely compromised to the point of no light perception. Indirect trauma can also result in posterior injury. If we keep in mind the segments of the optic nerve which are posterior to the globe, this type of trauma may affect the intraorbital optic nerve, the intracanalicular optic nerve, or the intracranial optic nerve. The intracanalicular optic nerve is most vulnerable to indirect trauma given the confines of the intracanalicular space with potential shearing forces. The intracranial segment of the optic nerve, as it rises up towards the chiasm, is second most vulnerable. Finally, the intraorbital portion of the optic nerve is the least vulnerable, as there is usually redundancy of this segment of the optic nerve within the orbit. This is another diagram showing the possible locations of injury. As we can see here, the intracanalicular portion of the optic nerve is within a very tight space. Should there be contusion injury of the intracanalicular optic nerve with edema, the nerve fibers and vascular supply can be compromised by swelling. The pathophysiologic mechanism of injury in traumatic optic neuropathy is believed to have two components, a primary followed by a secondary injury. The primary injury is believed to be due to mechanical shearing of optic nerve axons. Alternatively, there may be ischemia to the optic nerve from damage to the microcirculation with resulting contusion necrosis. This diagram demonstrates shearing forces on the optic nerve axons, which can lead to neural injury with subsequent apoptosis. After the initial injury, the secondary mechanisms come into play. It is believed that after ischemia, there is reperfusion which leads to the release of free oxygen radicals. This reperfusion injury may lead to apoptosis of the injured as well as uninjured neighboring axons. Regarding the clinical features of traumatic optic neuropathy, the degree of vision loss may be quite variable. The visual acuity may range from 20/20 to no light perception. In more severe cases, usually the vision is worse than 2400. Also, in up to 10% of cases, the vision loss may be delayed. In addition, patients typically may have visual field abnormalities. A relative afferent pupillary defect may be present in the affected eye from unilateral trauma. In cases in which there is significant injury to other organ systems and the patient is unresponsive and the diagnosis of traumatic optic neuropathy is uncertain, a visual evoked potential may be necessary to confirm the diagnosis. Regarding imaging studies for traumatic optic neuropathy, a non-contrast computed tomography of the orbits with axial and coronal thin cuts of approximately 1.5 millimeters with bone windows is recommended. This is helpful to rule out the following: fractures of the greater or lesser wings of the sphenoid, optic nerve sheath hematoma, subperiosteal hematoma, intraorbital or intracranial foreign body, and retroorbital hemorrhage. To better image the optic nerve and the sheath itself, an MRI of the orbits with and without contrast is necessary. This would better delineate an optic nerve sheath hemorrhage. In terms of the natural history of traumatic optic neuropathy, unfortunately, there are no good studies to date. We do know anecdotally that patients can and do improve, and it is even possible for those patients with no light perception on presentation to improve with respect to their visual function. The treatment options for traumatic optic neuropathy are controversial. In the past, based on the results from the second National Acute Spinal Cord Injury Study, or NASCIS-2, megadose corticosteroids had been considered an option. The NASCIS-2 had evaluated patients with acute spinal cord injury who were randomized to placebo, methylprednisolone, or naloxone. These results were extrapolated to cases of traumatic optic nerve injury. Within the study, megadose methylprednisolone at a loading dose of 30 milligrams per kilogram, followed by 5.4 milligrams per kilogram per day for 24 hours, was started within 8 hours of injury. This protocol was associated with a significant improvement in both motor and sensory functions compared to placebo. However, this study was criticized as to whether the clinical benefit demonstrated was actually the result of statistical bias. A follow-up study, the NASCIS-3, was also performed, though there were randomization issues. Since 1990, at least 16 studies of traumatic optic neuropathy have been published in their peer-reviewed literature, with a total of 715 patients. Based on these studies, approximately 500 patients were treated with steroid therapy for traumatic optic neuropathy. This therapy ranged from low-dose oral steroids of less than 100 milligrams per day, moderate-dose steroids of 100 to 499 milligrams per day, and high-dose steroids of 500 to 1,999 milligrams per day. Very high-dose steroids and megadose steroids were also employed in several of these studies. Surgical treatment for traumatic optic neuropathy includes optic canal decompression. This may be indicated if there are bony fragments noted impinging on the optic nerve. Also, in the absence of any penetrating trauma, but in the setting of presumed optic nerve edema within the canal, theoretically, canal decompression may reduce the risk of vascular compromise, thereby mitigating secondary injury. In the International Optic Nerve Trauma Study, 133 patients were enrolled. 85 patients received corticosteroids. 33 patients underwent surgical decompression of the canal with or without steroids. The remaining 15 patients underwent observation only. The results of the IONTS showed that visual acuity increased by greater than 3 lines in 32% of the surgery group, 52% of the corticosteroid group, and 57% of the observation group. However, one must keep in mind that this was not a randomized controlled study. There may have been bias as to which group the patient was assigned based on the severity of vision loss at presentation. In light of the study limitations, the authors concluded that, quote, neither corticosteroids nor optic canal surgery should be considered the standard of care for patients with traumatic optic neuropathy, unquote. The authors therefore recommended treatment decisions made on an individualized case-by-case basis. Since the International Optic Nerve Trauma Study, there has been new scientific evidence that megadose steroids may have potentially harmful effects on the central nervous system and also the optic nerve. In an animal model of traumatic optic neuropathy, rats underwent optic nerve crush for 5 seconds. The rats were then treated with intravenous saline or methylprednisolone at a dose of 30, 60, 90, or 120 milligrams per kilogram. The results of the study showed that the saline-treated group had the highest axon count. Also, there was a dose-dependent decline in axon counts with increasing doses of intravenous corticosteroids, with a p-value of less than 0.02. Other animal studies have also shown that megadose steroids may be harmful in optic nerve injury. In an experimental model of autoimmune optic neuritis, methylprednisolone increased apoptotic retinal ganglion cell loss. It has been hypothesized that steroids may inhibit a neuroprotective pathway that subsequently increases the rate of apoptosis. In 2005, the corticosteroid randomization after significant head injury, also known as the CRASH trial, results were released. Based on this trial, there were concerns regarding the use of megadose steroids in traumatic brain injury with increased rates of adverse events. The CRASH study showed a significantly increased risk of death in patients that received megadose steroids when compared with the placebo group. 25.7% versus 22.3% with a p-value of 0.0001. Based on these animal studies and human trials which suggest that megadose steroids may produce more harm than good, the trend has been to avoid megadose steroids. However, the potential role of lower dose intravenous or oral steroids in treating traumatic optic neuropathy is still uncertain. Finally, regarding future treatments for traumatic optic neuropathy, neuroprotection has been a subject of interest. Most studies of neuroprotection in animal models use surviving retinal ganglion cells as an outcome measure. However, the viability of retinal ganglion cells does not necessarily translate into preserved axonal function and thereby visual function. Nonetheless, it makes sense that treatments directed at preserving the axon, i.e. axoprotection, would be a more useful strategy for traumatic optic neuropathy. As of yet, there is little known about how to best protect an axon in traumatic optic neuropathy. In conclusion, at this time, regarding the treatment of traumatic optic neuropathy, there is no standard of care regarding optic canal decompression or corticosteroids. In the appropriate clinical setting, one may consider using IV methylprednisolone 250 milligrams every 6 hours for 24 to 48 hours, as recommended by Steinsaper and Goldberg. Regarding surgical decompression, there is no evidence that decompression is helpful. Patients with a visualized bone fragment impinging on a segment of the intracanalicular optic nerve may be considered to be the best candidates for decompression surgery. Also, one should consider holding off on surgery in patients who are unconscious and whose vision cannot be accurately assessed. The recommendations also include appropriate counseling, which should be given to the patient and the family about potential benefits and risks of treatment in order to help them make an informed decision. Finally, further studies are needed to elucidate the natural history of untreated traumatic optic neuropathy prior to determining if treatment would be beneficial or harmful. Thank you very much for your attention.